All right, now I'm ready. Okay. So our neurosurgery research at Lenox Hill, right now we have 39 IRB approved studies. We kind of have buckets of study types. Our biggest is our 20, we have 22 in interventional clinical trials. And what are interventional trials? Those are the ones that actually have some kind of intervention, whether it's drug, device, but it's some change. So it's not retrospective, it's prospective, and it's interventional. We have a bunch of tissue specimen collection studies. We send our tissue. We used to send it to Feinstein. We used to send it to New York Genome Center, Rockefeller. Right now, we have a partnership with Cold Spring Harbor that we send tissue to. We have a couple registries. We have and well, I'll get into this a little bit later. And then we have our device feasibility study. So that's basically kind of our study types. In neurosurgery, we have some specialty trials. Obviously, we have a big focus on neuro-oncology, two spinal surgery with Dr. Caridi coming on board. We've trying to expand our spine. And the same thing with our neuroendovascular with Dr. Cerulli coming on board. We're expanding our endovascular program, getting more stroke trials. We're in the process of trying to get some more aneurysm studies. And then I'm not sure if you heard from Dr. Ben Shalom, but his neuroplastic studies. And then we have device technology. I know Dr. Langer, we kind of have some novel devices that we've been trying to kind of pilot that we've been working on, and Dr. Ben Shalom. Our current enrollment for 2025 is at 41. I believe this is a little bit more. It's probably a couple weeks or so off. Last year, we had 120 subjects enroll onto a clinical trial, and this was the most in cancer and probably one of the biggest one in our health system. It's a big increase from the year before, so we're really happy about our enrollment numbers. Some new studies that I believe some of the team members will be talking about. We have our REACT study for MPH. Our office-based ultrasound blood-brain barrier trial, that's in process. We just got it submitted to the IRB, and we're in the process of submitting to the FDA for review. Oh, sorry, our eShunt. REACT is a spine trial. And then Dr. D'Amico, we have a bunch of connectomics trials that we're opening up recent in different areas, some in stroke, some in chemo brain, METs, and GBM. In our program, we have a big push for our investigators to apply for grants, apply for awards. Obviously, this helps research, this helps funding, this also helps just staffing. We have Dr. Caridi just got a therapeutics grant for one of our spine fellows, which is now Zoe. So we're happy that these grants actually make a big difference in people we hire and how we can grow our research program. Randy and Nadi both have had awards. Dr. Ben Shalom also had a recent award for that we now have a full-time neuroplastics fellow. As I said before, we have a big partnership with Cold Spring Harbor and Feinstein Institute. We used to send our tissue to Feinstein, now we send it to Cold Spring Harbor, but we do collaborate a lot with our team at Feinstein Institute. We have a bunch of programs and events in our department. One of our bigger ones, we have our Brain Tumor Biotech Summit that we usually do every other year. It's basically a culmination of investigators, lab research, research, clinical trials, sponsors, industry partners that we all come together. And typically, this is not a play. Typically, like you're not all in the same room, so we feel like this is a great avenue for a lot of different people who wouldn't be in the same room to get together and basically discuss what's happening and our different viewpoints. We also have our Brain Tumor Center Gala. We did our first one in last year. We had our second one this year, so it seems that's going to be an annual thing. We have a bunch of patients there, industry sponsors, and it's a great fundraising event for us, and obviously to bring awareness to our program and to Lenox Hill. Today's actually Glioblastoma Awareness Day, so we always try to promote what's happening here. Dr. Ben Shalom has an Advances in Neurotechnology course. At Cold Spring Harbor, we do a Banbury Brain Tumor course, which involves a lot of our bench research partners at Cold Spring Harbor. We have our clinical research internship in partnership with Auxiliary that's currently going on now, and that's for high school students. I'm sure you've heard from the Genesis Kids, and then obviously where we are now, we have our Brain Turns program. Our department and our brain tumor group specifically, we have a huge nonprofit collaboration. We've been basically developing these partnerships over many years with the ABTA, Glioblastoma Research Organization, Stash Strong, Brain Tumor Companion, and Oligo Nation. They support us, we support them. They have funded many of our projects. So it's a great place to, they also promote a lot of our studies. They refer patients, any patients they have that they send to us. So nonprofit collaboration is really important in our department and basically in our space for uh, brain tumors and other disease areas. All right, so here's basically a quick overview of our research portfolio. Like I said, we have a big brain cancer trial portfolio. I'll get into a little bit about our intra-arterial program and our basically our blood-brain barrier program. You'll hear from some of the other team members about specific studies, but we have a big portfolio for neuro-oncology. We also have our spine trials, our databases, and databases are very, very important. Entering data, uh, collecting data, making, use of all of our patients that we have is very important. And then we have our neuroendovascular trials, which have our interventional and our humanitarian device trials. So, so for our in our neuro-oncology trials and what makes our program very special and very kind of different from other institutions, we're able to offer, and this is why we've built our portfolio over the last many years of creating this kind of dynamic that at any point in a person's disease status that we are able to offer them a clinical trial. As you know, glioblastoma, it's a devastating disease. So sometimes patients, right off the bat aren't looking for clinical trials. So at any point we're able to do this. So for pre-diagnosis, this is before they even get surgery, we're able to offer them two trials. That was our surgical tissue flap and our IMVAX that's now close to enrollment. And then we have our tissue collection studies. After diagnosis and prior to initiating standard of care, and the standard of care is 6 weeks of chemo RT, we're able to offer them our two intra-arterial trials, our intra-arterial cetuximab and our intra-arterial Avastin trial. Our Cantex 1 is closed, but basically these two trials start before before they start chemo and radiation. They get a dose of IA cetuximab or IA Avastin prior to starting chemotherapy, and then they get two additional doses 3 months apart. And then after they finish their 6 weeks of chemo RT and prior to initiating their maintenance standard of care, and maintenance standard of care is 23 days off, 5 days on of maintenance Temodar. And that would be our CAPTAIN trial and our ONC201 trial. The one that just closed is our Mimivax trial. That's our vaccine trial. And then after, they're in their disease process, if they end up getting a recurrence, and they're undergoing surgery, we're able to offer them our Omentum trial and our SonoCloud trial. This is actually in the wrong bucket. SonoCloud is a device slash interventional trial that should be under recurrence. So those are our two trials. And then after they have surgery, we're able to offer them again our intra-arterial Avastin trial, intra-arterial cetuximab trial, our Frontier trial, which is Yttrium 90, and then Respect if you have leptomeningeal disease. With this, our national average for patients who enroll on a clinical trial is 60%, and the national average is at 5%. And this is because we're able to offer so many clinical trials at different time points in their disease process. Like I said before, we have a huge focus. The reason why it's hard to treat glioblastoma and brain cancer is because you have a blood-brain barrier. Obviously, you need the blood-brain barrier to protect your brain from everything coming into it. But when you have something in your brain, like a tumor, this is when we need to disrupt the blood-brain barrier. So we have different groups of our clinical trials, which is what how we try and disrupt the blood-brain barrier. We have our intra-arterial delivery trial. For those of you who don't know, for typically you get drugs given intravenous, and now we are giving it intra-arterial, which consists of a overnight stay in the angio suite. Um, and this is we do it endovascularly. So that's for our IA Avastin, IA Cetux, and our Y90 for the IA Cetux and Avastin. We have that in the newly diagnosed and in the recurrent sitting. Then we go to our surgical trials. I don't know if you heard Dr. Bookvar speak yet, but he talked about our FLAP and our Momentum trial. Not only does that disrupt the blood-brain barrier, but it also provides immune response for getting drugs in and helping basically like a conduit for drugs into the brain tumor cavity. Then we go to our ultrasound studies. Our ultrasound studies, which is our SonoCloud and our Office ultrasound blood-brain barrier disruption trial. And I just want to really emphasize how research works and how big of a network and collaboration is needed to run an operation like we do. Not only do we have our staff here, our investigators, our surgeons, but we have our PIs, our research coordinators, our nursing staff, ICU staff, all of our admins that help coordinate visits. We basically interact or have interacted with all departments at the hospital, whether it's pathology, microbiology, radiology, neurology, cath lab, pharmacy, central sterile. It's very important to have good relationships with every department because at some point in research, you will always need them for something. Our kind of admin and regulatory portion, I think some people forget about how important the the startup process is. So we have our IRB, we have our clinical trials office, which does all our budgets, contracts, finance, billing. It's a huge admin component of research that some people I feel like don't realize. Like but even before we start doing any intervention, it's more paperwork than anything. And then we have our external entities, which are FDA, clinicaltrials.gov, our foundation nonprofits that we talk about, and then our IRBs, and of course our other institutions. We have a couple multi-center trials that we're onboarding now for some of our studies. So we interact with a lot of other institutions. We're actually working right now with Dana-Farber for some big stats projects. So we interact with a lot of other institutions. They refer to us. We help, it's a big community. So we always want to have good relationships with everybody. And, for those of you who are thinking about research, always think about the people you'll need, the people who you'll interact with, because they are very important in every aspect. And that's it for me. Now Sarah is going to go over one of our acute stroke trials. Sarah, you want me to keep sharing or do you want to take over?
Whatever's easier for you.
It doesn't matter.
Okay, I'll let you keep it up then.
Okay, just tell me when to.
Okay, thank you. Hi, everyone. So I'm going to talk to you about one of our interventional stroke trials. It was one of the first more acute trials that we started up with Dr. Cerulli as the PI. So the title of the study is a randomized placebo-controlled double-blind multi-center study of the safety and neuroprotective capacity of SCP-776 in subjects undergoing endovascular thrombectomy for acute ischemic stroke. We'll be getting into more of a breakdown of what the title means. It was a sponsored trial, so we worked with a pharmaceutical company called Silver Creek. Next slide, please. Okay, so to kind of go over it, the study drug that we're looking at is called SCP-776. We'll talk about more about how it's made up, but it's given to patients either before they undergo a thrombectomy for their stroke, or within 4 hours after receiving a thrombectomy. It's a phase 2A and 2B study, focusing more on the safety endpoints, safety and efficacy of the drug itself. Patients were randomized to the drug at either 3 different doses or to placebo. And it was double blinded, which means that neither the patients, any of the research staff, or the pharmacy team knew which assignment the patients were given for the drug. And multi-center, like Tamika kind of touched upon, just means that there are other institutions that we collaborate with that are also enrolling on the study. So you'll see there were different part A and part B. Basically, we're just broken up into different dosing regimens. So you can see here an example of one of the cohorts the patients might be randomized into, and then also placebo arm. And then part B, they basically took whichever dose was most effective and had the best safety profile from part A, and they used it in part B to enroll additional subjects. So they looked at that dose and put it up against placebo. And the whole goal of the drug is to help protect the brain and protect the cells from dying after an acute ischemic stroke. So you can kind of see here that what happens during a stroke, a cell gets injured, and either it's able to survive, it undergoes apoptosis or necrosis, and the goal of the SCP-776 is to allow the cells to make a recovery instead of going into cell death. Next slide, please. So what is the drug itself? It's made up of 3 different components. One is an insulin-like growth factor protein. That is mainly the treatment arm of the drug. So it's what's inhibiting the apoptosis and protecting the tissue. There's also a half-life extender, which just allows the drug to stay within the body for a longer amount of time. And then the targeting arm is the ANX-V, which binds to the surface of cells that are in early apoptosis. The dose is administered, like I said, either prior to thrombectomy or within 4 hours after, and then again 24 hours after the first dose. And what we're looking to see, the endpoints are to see if it will inhibit apoptosis and limit any ischemic damage caused by the stroke itself. You can kind of see the picture there of how the pathway works. Next slide, please. So when we're looking to enroll patients into studies, we look at eligibility criteria, which is made up of inclusion and exclusion criteria. So this is an example of some of the main inclusion exclusion for this particular study. It actually does not include the full extensive list that was used for this study, but some main points were that they had an ischemic stroke that was needed to be treated by an endovascular treatment, so the thrombectomy itself. They had to have an NAHSS score, which is the stroke score greater than or equal to 6. And then the location of where the stroke occurred, where the occlusion was, also matters. And we also look to see at how independent the patients were prior to them having a stroke, which we call MRS score, modified ranking score. And then some key exclusion, we also look at the CT scans that are typically done during a stroke workup. And from that, we get something called an aspect score. We also did not include patients that received thrombolytic therapy. So like T and K were not allowed. So just some things that we look for. And in order for a patient to enroll, they have to meet all the inclusion criteria, and then they cannot meet any of this exclusion criteria. Next slide, please. A little bit about the workflow and how we kind of conduct the study itself. So this being one of our first acute studies, it was kind of a new workflow for us. When a patient or when the team is made aware of a stroke, they activate what's called the stroke team, and us as part of the research staff ended up being incorporated into that stroke team activation. So we had actually like a beeper, which you could see here, that was used to call us. So we were on call 24/7 for this study. Once we were notified of a patient, we would look them up in our electronic medical record systems and be able to start screening them to make sure that they meet those inclusion exclusion criteria. We'll have the investigators look at the imaging scans to make sure that they are a candidate for thrombectomy and for this study. And then we'll go and we'll consent the patient. And a lot of times you can imagine these patients are not able to consent themselves due to them just having a stroke. So we use something called a legally authorized representative or an LAR to consent a patient. So most of the time it's a patient's family member that will be able to consent on their behalf. After the patient is consented for study, we will perform some screening assessments. And if everything's confirmed in terms of their eligibility, we randomize them. And we use an electronic system for that notifies our pharmacy team of which dose or placebo the patient was assigned to. We would go and pick up the drug from them and administer the drug to the patient. And along that, there's other assessments that need to be performed throughout the patient's hospital stay. And then we also look at them at day 60 and at day 90. And then they've completed the study. Next slide, please. But yeah, that's pretty much what Arpeggio is. And thank you guys. Sana's gonna take over now and tell you about one of our other studies.
Okay. Hi, everyone. So my name is Sana. I'm the Senior Research Project Manager here at Lenox Hill Neurosurgery. I'm going to talk about briefly the Rhenium trial that we had done, which is now close to enrollment at Lenox. It occurs when a patient has leptomeningeal disease. Next slide, please. Okay, so what is rhenium? It is basically chelated rhenium, which is encapsulated within the lipid vesicles, nanoliposomes. So it's a dual energy emitter. So the beta and gamma has a long half-life. It's a short average path length of 2 millimeters, so it's precise. And its delivery has a low dose rate, so it's safer for surrounding organs within the area that the patient's getting the dose at. And then it also has high radiation density, so it overwhelms innate DNA repair mechanisms. The rationale from the sponsor that was given to us for this trial is that the liposomal encapsulation has been shown to prolong retention in the brain and the cerebrospinal fluid. So it delivers high absorbed doses of radiation to disease within the leptomeningeal space while limiting the exposure to the surrounding organs at risk. So those include the brain, the spinal cord, bone marrow, and other non-target tissues. Next slide, please. Okay, so the primary objective of this study was to characterize the safety. So it's a phase 1 study, and it was characterize the safety and tolerability of a single dose of the rhenium through the intraventricular route and to identify a maximum tolerated dose or a maximum feasible dose. So essentially just making sure that there was a safe dose, a single dose that you could give to patients, and whether there was a maximum or a maximum feasible dose that the patients could tolerate. The secondary objectives were to characterize the pharmacokinetic and dosimetry profile of a single dose of rhenium when it was administered intraventricularly via an Ommaya reservoir, and then develop multiple dosing strategies for any future clinical trials, determine the overall response rate, the duration of response and progression-free survival, and overall survival. And then the exploratory objectives were to perform analysis on the CSF fluids pre and post administration of the rhenium to see any pharmacodynamic markers of the efficacy of the rhenium. Next slide, please. Okay, so this is an overview of the workflow that you would have if a patient were to be enrolled into the clinical trial. Like all clinical trials, we have inclusion-exclusion criteria where we check to see if a patient would be eligible. So for this study, the patient would be, period of 5 weeks to be screened. If they have leptomeningeal diagnosis, you would go to see if they have an Ommaya reservoir, which is basically how the rhenium is delivered. It's intraventricularly. If they don't, then they would, go to our neurosurgeon, have an appointment with them, have the procedure done in the OR. If there is no abnormalities, then we continue to go on to give the dose of the rhenium. But if not, then we have to mark the patient as a screen fail. And then the termination visit will happen 2 weeks if there is after any disease progression after that. But essentially, once the patient gets the dose at day 1, it's quite an intense trial because there's a lot of monitoring involved. The patient comes in on day 1, they receive the dose, they have to do a lot of imaging, which I will talk about in a minute, and then also collecting some blood, urine, CSF samples during this time period. And then the follow-up is every week until 4 weeks, and then it's every 2 months for survival. Next slide, please. Okay, so the inclusion-exclusion criteria for this trial is super important. This is kind of a high overview of it. It's a little bit more in depth when you do actually go through the inclusion exclusion, but this is the main ones that we look for, that the patient has proven and documented leptomeningeal disease, and they meet the requirement per the criteria, and then they have a KPS, which is a Karnofsky performance status, basically how well they can conduct their day-to-day activities or their daily activities of living, and it has to be within 60 to 100. So a clinician would do a physical and neurological exam and some other assessments to assess that, and that the standard organ function requirements are also within the range. And then the exclusion criteria, some of these terms are very medical, so don't worry if you don't understand them, but if there's obstructive of symptomatic communicating hydrocephalus, if there's fluid in the brain ventricles, if there's ventroperitoneal or shunts or programmable valves or any contraindications that would not have the patient to get an Ommaya reservoir. Any patients who've had, this is a very important one, a lot of patients were actually excluded because of this one, which is the radiation. So if they've had any prior spinal cord or whole brain radiation, they were excluded from the study, and any standard concomitant illnesses that would restrict them from being enrolled in this trial. So again, the primary objective was to determine the maximum tolerated dose and the feasible dose. And you can see here in this diagram the way that the dose is delivered. So the neurosurgeon essentially does a procedure to place the Ommaya reservoir, which is a way that the rhenium is then injected intraventricularly, and it's done in an outpatient setting, the actual injection of the rhenium, but the Ommaya reservoir has to be done within the OR. Next slide, please. Okay, so here is what I was talking about, where it was pretty intense in terms of the monitoring for the patient. So when a patient gets the dose, and this looks pretty complicated, so I can break it down, but when the patient gets their first dose, you can see it's separated with day 1, day 2, day 3, day 7, day 28, and until progression. So this is the entire cycle of when the patient is on trial with us. So for day 1, I'm just going to go through the first example. Once the patient completes the injection of the rhenium, we have to do what's called a whole body planar scan, and this is in the radiation and nuclear medicine department where they have the machine. So they have to do it close to that area, because they have to then get a scan at the end of the infusion right away for the whole body, and then also 3.5 hours after the infusion. And then you also have to do a SPECT CT. And basically, this SPECT CT shows us where the dose was delivered. Once it's superimposed with the whole body planar scan, the whole body is to see if there was any rhenium elsewhere in the body that was given or, kind of transfused. And then it's done at the end of infusion again, and then 30 minutes after the first scan is complete. So it can get a little confusing. So we have to be very on top of it once the patient's completed the dose, and the whole team, like Tamika was saying at the start, you have to have good relationships with the whole multidisciplinary team, because we needed the help of nuclear medicine, the radiation safety officer, the nuclear medicine techs were with us, Our whole research team was there, the neurosurgeons. So everyone kind of plays a part to make a trial successful. And then with the samples, you also have to collect urine samples. And so you basically give the patient a jug, and then anytime they have to urinate within the 0 to 24-hour mark, they use that jug. And then there's blood samples that we need to take, just for example, on day 1 at 1 hour, 2 hours, 3.5 hours post-dose. Then we also have to collect CSF for radioactivity, and then another 2 CSF samples for other testing, which we then ship to the sponsor on the same day. And then this kind of goes on with day 2, the same process. And then if you look at the plus or minus 6 hours or plus or minus 2 hours, that's basically a range that we can't deviate outside of. So if a patient got their dose at 9 a.m. on Monday, then the next, blood work has to be done at 9 a.m. On Tuesday within plus or minus 2 hours. So between 7 a.m. to 11 a.m., we have to collect that blood sample. Okay, and then this is kind of what we use to follow for the entire cycle. Next slide, please. Okay, so just to wrap it up, basically for the phase 1 trial, before we started, they had a part A of the trial, and they always kind of give us information about what they found, and then they were doing part B with us. So they haven't summed up the results for that yet, but I just want to give you some summary. The 10 patients received a single administration over the 3 dosing cohorts, so they had separate doses to see which one was the most tolerable. What they found was that radiation persisted beyond 7 days in the cerebrospinal fluid. There was a 50 to 90% reduction in tumor cells in the CSF at 28 days, and it favored a safety profile with no dose limiting toxicities. And then 8 out of the 10 patients that they treated lived up to 1 year. And then for safety, they had no treatment emergent adverse events greater than grade 1. The most common reported adverse event was a headache, and then any non-treatment related adverse events were primarily related to an SSKI administration, which is what they give for the thyroid to protect the thyroid from radiation. And then 1 patient safely received a second administration. But just to wrap it up again, this study was very interesting. We got to see a different part of research and the way it was conducted, especially for leptomeningeal disease, and it kind of taught us a lot in terms of how to build a really thorough workflow and follow the protocol to a T. Okay, that's it for me. Faith is seeing a patient, Tamika. So do you want us to go over it?
You want to do it?
Yeah, we can briefly go over it. So another trial that Faith leads, our senior research coordinator, is called the ESHUNT trial. It is the study to evaluate the safety and effectiveness of treating normal pressure hydrocephalus, and it's by the company Cerevasc. And Dr. Cerulli is the lead PI on this. So just a brief overview on hydrocephalus. There's obstructive hydrocephalus, where the CSF flow is blocked by a physical obstruction within the ventricular system of the brain. And then there's also communicating hydrocephalus, so CSF flow and absorption are impaired after it exits from the ventricular system of the brain. And then communicating, the etiology of the hydrocephalus of communicating is that it's congenital, so conditions present at birth, or it can be acquired, so it develops as a result of neurological conditions, including the head trauma, infection, subarachnoid hemorrhage, or brain tumor. The target population for this trial is patients with normal pressure hydrocephalus, NPH, which affects older adults where the ventricular enlargement can occur often without any known cause. And the most common symptoms that the patients have are headaches, vomiting, neurological dysfunction, coma, and potentially death. And then the CSF is continually, so just a little background, is continuously produced in the ventricles and absorbed from the subarachnoid space into the venous system through the arachnoid granulations. And then hydrocephalus occurs when the natural absorption of CSF is impaired. Next slide, please. So the treatment today for hydrocephalus is a ventricular catheter that's placed in the brain, the lateral brain ventricle, via a burr hole drilled in the skull. There's a catheter that's connected to a valve that's placed under the skin. There's distal tubing that's tunneled under the skin, and this is called a VP shunt, and it provides a conduit for excess CSF flow from the ventricle to the peritoneal cavity. Just some facts on the complication/failure of this. What the complications, the most common one is obstruction or occlusion. There's ventricular catheter misplacement, overdrainage, infection, and some mechanical failures. Next slide, please. Okay, so what is eShunt? So the eShunt trial basically is a minimally invasive endovascular device that was designed to mimic the natural arachnoid granulation system for CSF absorption. So you can see here on the right side of the page, you've got the anchor that's present. That's about 3 millimeters by 3.5 millimeters, which prevents migration. You've got the shunt body, and which is about 35 millimeters in length. And then you've got these distal RO markers and proximal RO markers, which also is called a slit valve. Next slide, please. So the eShunt implant location is the inferior petrosal sinus, a venous channel branching from the jugular vein, and the catheter navigation from the femoral vein to the IPS is well known to the interventional, so the neuroendovascular and interventional physicians, and it's accessed in several established neurointerventional procedures, including IPS sampling. Next slide, please. Actually, Faith is back, so she will take over to talk about the rest of the study.
Faith, you're muted.
Oh, there we go. So like they were saying about the eShunt study, basically it has a very intense screening process. There's a lot of different inclusion, exclusion criteria that need to be met, and a lot of different screening assessments that need to be done. Most notably, they look for a TUG test, which is a physical therapy test to see how fast a patient is walking, and they also measure different characteristics of their gaits, because all of that information gets sent to a secondary committee which reviews these images to check for secondary gait characteristics that are indicative of hydrocephalus. And then patients also get imaging done, CTs and MRI scans, which are done under very specific sequences that are captured. So that could be sent to an anatomical screening committee. And they look at these images to assess the safety to be able to deploy the eShunt device. And after patients go through all of these different exclusions criteria, there's many different steps in here which they can screen fail out of the study. So that could be if their LP pressure isn't high enough, if they don't have a certain score on their MoCA exam, which is an exam that we use to check their neurocognition. If their anatomical screening is incorrect, if they don't improve in their TUG post their lumbar puncture procedure. So there's many different steps in which patients can fail out of the study. And sometimes that doesn't even mean that they don't have hydrocephalus. It just means that they aren't eligible for the trial. So we've had patients who have failed out of the study, but still went on to continue to get the regular normal VP shunt procedure. And then after patients pass all of the screening criteria, then they're randomized. It's a 1-to-1 randomization. We just plug them into the computer, and then they spit out whether or not they've been randomized to the eShunt device or the VP shunt device. And then patients are followed up every 3 months, and then for the first year, and then yearly afterwards, just to check for an improvement in their gait, to compare AE rates that happen between patients who have the VP shunt and patients who have the E shunt. Um, yes, that's just basically like the design of the trial. And next slide. Oh, that's it. And that's the E shunt trial.
Awesome. Thank you, everyone. And does anyone have any questions for us?
Yeah, let me look through them really quick. Somebody had asked, could SCP-776 potentially work against cell cannibalism and netosis? Has it been used for any other conditions like cancer?
Hi. Sorry, one second. Hi. Yeah, so SCP-776 was previously used in Alzheimer's patients, actually. They did some phase 1 studies with it on humans. And unfortunately, the data just wasn't strong enough to prove it that it was efficacious or had a good enough safety profile. Well, did have a good safety profile, which is why they're able to use it for the Arpeggio study and in stroke patients. But it didn't show good efficacy when it came to treating patients with Alzheimer's, unfortunately. Thank you.
Yeah, thank you. There's another question about how the e-shunt how is the e-shunt delivered in the Stride RCT?
I'm sorry. I'm sorry. Can you repeat the question again?
Yeah, no worries. They're just asking how the e-shunt is delivered in the Stride RCT.
So basically the way how the procedure is done is that they make a small incision in the groin, and then they thread a catheter up through the veins all the way up to the brain, to the ventricular space that's there, and then there's an anchor where it's deployed in that space. So it's a very similar procedure to how patients get like um cardiac stents done or like aneurysm clipping. So this procedure is done a lot of times to deliver and other kinds of devices and deliver other kinds of like drugs into the body system minimally invasively. But they just go through that same route, and then it's implanted in the ventricular space.
Thank you. There's another question asking about how you go about telling a patient they don't qualify for these trials and possible disappointment.
So yeah, it's a difficult conversation. A lot of our the trials that we do have that are randomized, that they're not getting an intervention, but it's hard to tell them, you know, like they obviously they want the treatment, they want an addition to standard of care. So typically we tell them, you know, you don't qualify for this, but obviously the standard of care is still, you know, standard of care, and that's what's been proven. So there's other trials down the line that you may be eligible for, but you know, this is the way science is set up, and this is the way the FDA wants us to have a randomized trial to prove our efficacy. So it's difficult, but you know, there are other options, and thankfully we have other trials that they can qualify for in the future.
Perfect. Thank you. There's another question asking how they can learn more about the CP-776 trial, if there's any thing that y'all can provide where they could learn more about that.
Hi, yeah, I can drop a link to clinicaltrials.gov page, or if you Google Arpeggio and SCP-776 and go to the clinicaltrials.gov page for it, you can find more information about it there.
Perfect. Thank you. And then we have another question, or multiple questions, I guess, kind of talking about maybe if you guys could give our brain turn some advice on how they can go about, you know, getting involved in research and gaining those opportunities.
I think internships are great. I think programs like this are great. I think partnering or establishing kind of relationships with investigators, people like us, are very helpful for your career. Obviously, there are limitations, what you can do if you're not fully on the IRB on the IRB study. So, but doing internships like that where you can have firsthand experience in research. For people that I know are currently here and have gone to medical school and gone other places, whether it's PA school, NP school, they think being in clinical research is really very, very valuable, not only, as a career choice, but also for future development in any career you want to get into. So establishing relationships, reaching out to people. Obviously, people are busy, everyone's not going to respond, but I think specific programs that have connections like this are great.
Yeah, perfect. And then there's another question asking if y'all could talk about your journey and what inspired you to go into research.
Does somebody else want to take that?
I can do it. Sorry. Yeah. So I actually moved to New York from Australia, and I really wanted to do research. My background is in dosimetry, which is treating patients using radiation. So I was a dosimetrist, so the physics part of it. So I was a dosimetrist back in Australia. I did all of my undergrad and master's back there, and I kind of dabbled into a little bit of research for breast and prostate cancer, and I really liked it. So I basically just packed my bags one day and moved countries. And, you just have to find your way one step at a time. But I think really looking for what you're interested in, and research is so vast. There are so many opportunities that are out there within the different things that you could do, whether you want to be a monitor, whether you want to do the finance portion of research, or if you want to be within what we do, like research coordinator, project management, being, getting your hands dirty with the clinical trials and working with patients, regulatory, all of that stuff. I had no idea about any of that until I met Tamika, and we kind of went through it step by step, and she taught me everything that she's, had experience over the last so many years, and we all kind of collaborated together. But my prior experience in dosimetry and working in healthcare was very helpful because I was able to take that knowledge and, use it in some of the trials that we work on today with radiation. But again, like, research is such a vast field. I think you need to research what you really want to do and what interests you, and you kind of meet people that come along in your way and show you the right path.
Yeah.